Hello and welcome. Thank you for attending our webinar. I think we're about ready to begin, 2:30 on the dot. But firstly, I'd just like to ensure that everyone can hear me. So if you can you please type yes into the chat box, which you'll find on the left-hand side of your screen? Amazing. Okay, thank you so much. I'm seeing lots of yeses, so that is great. So welcome to Asthma Canada's Severe Asthma Charter Series webinar on severe asthma diagnosis and access. Our webinar series has been made possible through educational grants from AstraZeneca, Novartis, GSK, and Sanofi Genzyme. So today's webinar on diagnosis and access is an incredibly important topic for Asthma Canada and our community, and I know many of you have been looking forward to this. So thank you so much for joining us. My name is Kristen Valwa, and I'm the Manager of Communications, Programs, and Public Engagement at Asthma Canada. I will be your host today. But before we begin, I just want to go over some quick points. This webinar is being recorded, and it will be uploaded to our websites shortly. So please do feel free to share within your networks once the recording is made public. All attendees are muted, but at any point, if you have questions, comments, issues, etc., please type into the chat box, which I'll be monitoring throughout. There's also a little blue question mark at the top of your screen, and you can type your questions there. There will be a Q&A at the end, but absolutely make sure to type any questions in as we move through the presentation so you don't forget. So very quickly, I'd just like to highlight some of our work. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. At the heart of all we do is our vision to empower every child and adult with asthma in Canada to live an active and symptom-free life. We are committed to improving the lives of the Canadian asthma community through education and support services, advocacy, and research. Asthma Canada encourages self-management by helping our community take control of their symptoms. We do this through our educational resources and services like our Asthma and Allergy Helpline and webinar series just like this one. We're also committed to bringing your voice to the forefront of policy decisions that affect our community, advocating on important issues like sustainable clean air and energy, choice and access to treatments, and access to medication in schools. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. Our national research program supports graduate level students studying early or late onset asthma. Much of the work we do is through our community of volunteers and members across the country. People living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to improving asthma care and quality of life. The Asthma Canada Member Alliance is a free membership of Canadians who engage in all the work we do and who provide support and input into our initiatives. So if you haven't already, I would absolutely welcome you to join us. And now I'd like to introduce our distinguished presenter, Dr. Samir Gupta, who is joining us live with his webcam on. So thank you so much for your friendly face. Dr. Gupta is a clinician scientist at the Lee Koshing Knowledge Institute of St. Michael's Hospital and an associate professor in the Department of Medicine at the University of Toronto. He is a staff respirologist in the Division of Respirology at St. Michael's Hospital. He completed his master's degree in clinical epidemiology at the University of Toronto, followed by a fellowship in knowledge translation research. His main research interest is in knowledge translation across the spectrum of respiratory illness, with a focus on electronic tools for behavior change. He also has an interest in rare lung disease research methods and the hepatopulmonary syndrome in particular. He has a specific interest in science communication and serves as a medical correspondent for various media outlets. I know I saw his face on the CBC a ton in these last few months, helping Canadians make sense of pandemic data. He also serves as chair of the Canadian Respiratory Guidelines Committee and holds the University of Toronto Michael Lock Term Chair in Knowledge Translation and Rare Lung Disease Research. So thank you so much, Dr. Gupta. It is a pleasure to have you with us. And I'm happy to pass the presentation over to you.
Thank you, Kristen, and thank you very much to Asthma Canada for inviting me. I'm going to share my screen. and start my slides. So hopefully everyone can see those slides. So today's talk is part of the Severe Asthma Charter series. And we're going to focus on diagnosis and access. I'm going to start with my usual presenter disclosure. I don't have any relationships with private industry. I do have grants from CIHR, Lung Health Foundation, and the provincially funded Academic Health Sciences grant. I do some educational programs for the Lung Health Foundation. I am chair of the Canadian Respiratory Guidelines Committee, which is relevant because we will talk about some Canadian guidelines today, Canadian Thoracic Society guidelines. I co-chaired the Health Quality Ontario Asthma Quality Standards, and I'll touch on those. And I lead a company called EPOC, which does evidence at the point of care and provides guidance to providers on how to offer best care. So the focus areas for today are threefold. First, it's making sure that you have asthma. In other words, getting the right tests for your diagnosis. The second is asking the question, do you really have severe asthma, or is it just uncontrolled asthma? Really understanding the difference between those two. And then what factors other than the asthma itself may be contributing to your symptoms of severe asthma. And so...
Sorry, Dr. Gupta, I'm just going to stop you there. I don't think we can quite see your slides yet, so give you a moment just to...
Thank you for stopping me, because I'm...
No problem. It is great to see your face, but your slides are also great.
Okay, there's an extra click that I'm now seeing. This might do it. Sorry,
Fantastic.
I couldn't see the chat. I couldn't see the chat, so...
No, it's a lot going on. Everyone can see this now, I believe.
Can you see it?
Yes, you got a "we love you" and a "fantastic," so I think we are good. Sorry to interrupt. I will...
Sorry about that, everyone, but you didn't miss anything much. This is really the first slide. So the focus areas that I mentioned, and it's a little bit, maybe a little bit different than the usual focus for the series, in that I maybe a little controversial, in that I want patients out there to ask themselves the question, do they really have severe asthma? And I think all of us as providers need to keep asking this question when we're seeing someone that we think has severe asthma, to just go back to fundamentals and ask, do they really have severe asthma? Do they really have this disease? And so asthma, we know that asthma is a common condition. 1/3 of Canadians will get diagnosed with asthma over a lifetime. It's the third most common chronic disease in the world. It affects about 8% of the population. In Canada, that's 2.5 million Canadians. The economic burden is approaching $2 billion a year. So it exacts a huge toll on our society, on our healthcare system, on productivity, et cetera. The prevalence of asthma, cumulative prevalence, continues to increase across ages. So if you look at 1996, 90 people per 1,000 had asthma in the population. And all the way fast forward to 2018, that had risen to 155 people per 1,000. So we are seeing more and more people cumulatively in our population having asthma. That is one of the reasons that Health Quality Ontario, which is now part of Ontario Health, but is a quality agency, a wing of the government in Ontario that helps to drive and improve quality of care, produced these asthma quality standards, one of the many standards that this organization has produced. And I'm going to come back to these periodically, and I do want to start by just sort of introducing this idea. These standards the work started a couple of years ago around asthma, and it was divided into two standards. One is for asthma in children and adolescents. The other is asthma in adults. They're very similar, and I'll go through some of the concepts. Slight differences, as you know, between how we treat, even diagnose asthma in different age groups. And the final standards were released just this past fall. So a very valuable document around how we should be managing asthma. What the standards do is they inform clinicians and patients about what high quality care should look like. The focus is on conditions where there are large variations in care, and that we know there are gaps between how we should be caring for our patients and how we end up really caring for our patients in real world situations. And there are many such conditions, many chronic conditions, and asthma is one of them where we know we can do better. And the evidence from the literature is what is used to develop these quality standards, very much in the same way as what you see in guidelines. In fact, a big part of the reference material for this process of producing quality standards is to consult with guidelines, Canadian and international guidelines. Importantly, and I wanted to mention this particularly on this talk, every standard, including our asthma standards, comes with a patient guide. And that is a patient-friendly, in patient language type of guide to really tell you as a patient what good quality asthma care should look like for you, and to empower you with that information so you can ask the right things of your provider. The example I've put up here is the COPD one, just as a reminder that in case there are folks who have COPD or are interested in COPD on this call, there is also a standard for COPD. But there's a patient guide for each of these, including the asthma one. I'm going to just run through what the quality statements are in the asthma quality standard, and there are 6 key statements, same ideas across the adult versus the pediatric standards. Here are the 6 key themes and statements that you'll find. The first is diagnosis, making sure that we get everyone objectively diagnosed, properly diagnosed. The second is asthma control. We've got to assess our patient's asthma control according to guideline criteria. The third is medication. We got to treat our patients according to the escalation and de-escalation regimens that are based on evidence and that are found in our guidelines. We've got to empower patients to self-manage. That's achieved through an asthma action plan where they have a plan, tells them what to do if they get worse, if they get a cold, or if they have an allergy exposure out there, how they can self-manage and auto-titrate their medications in order to avoid the need for the emergency room or running back to the clinic. Referral to specialized asthma care, when that should happen and how that should happen, that becomes particularly relevant for the severe asthma population. And finally, follow-up after discharge, ensuring that when someone does go to the emergency room or does end up admitted to hospital, they have a relatively soon follow-up in their primary care context, whether that's with the family doc, an asthma educator, a nurse practitioner, and so on. And so particularly thinking about the topics that we want to tackle today, and the reason I bring up the standards is that there's a lot of overlap with concepts in the standards. The first is diagnosis that we're going to touch on. The second is understanding asthma control. The third is really making sure that we have patients on the right medications for their level of control. We're not going to specifically talk about referral to specialized asthma care, but I circle that because that really is what thinking about specialized care really is what severe asthma is all about. That's the threshold that we're generally advising, in adults at least, where we need to refer to specialized care, when in primary care we become aware that somebody has severe asthma. And the reason that it's important to sort of to have standards and to do talks like this and to think about these problems is that we know that there are very important and persistent evidence to practice gaps in asthma management. That means gaps between what the scientific evidence tells us, what we know we should do, and what practice actually entails in the real world. There's still a gap there that we need to bridge. We need to do better in practice. And just to give you a bit of a historical perspective on Canadian data there, this is a study done by a colleague of mine, Ken Chapman, in Toronto. In 2001, they did a broad survey of patients with asthma in the country, and they found that we were doing really poorly with our asthma patients in terms of achieving our guideline targets, getting them under control and treating them the way our guidelines tell us to treat them. They repeated the study 5 years later. This is a study called the TRACK, or the Reality of Asthma Control Study. And they found very much the same thing. Those gaps were not diminishing much at all over time. And now fast forward 13 years later, myself and a few others asked the same question. How are we doing with respect to doing the things that guidelines tell us we should do for our asthma patients? Instead of doing a sort of community-based survey, we went into primary care settings and we actually looked at charts and we read, how are these patients being treated? What were they being prescribed? What questions were being asked? And again, we identified these same very large gaps in the quality of care that very much were persistent. And we're talking really about 20 years now. We're not seeing a lot of movement on a lot of these gaps. And the reason is that a lot of these things are complex. We're asking primary care providers to do some complex things. And in many cases, we're not yet empowering them with the tools to do those things. But that's why it's important to have these conversations. And the first thing I want to focus on is diagnosis. You can't have severe asthma if you don't really have asthma. And so the first question is, do you have asthma? And how do we make sure that you get the right tests to ensure that you have this diagnosis? The quality statement around this from the quality standards says it divides it by age. And the reason for that is that people younger than 6, so kids 1 to 5, can't reliably perform the breathing tests that we typically use for diagnosis. So we say in children over 6, adolescents who are suspected of having asthma, they should have a spirometry. That's the first test we do. If it's negative, they need other lung function testing to confirm. In children 1 to 5, we don't have spirometry as an option. So we document signs and symptoms of that airflow limitation we call the typical finding of asthma, which is narrow airways, and reversibility of symptoms with medications. Now, symptoms get better when you treat, and you're not suspecting an alternative diagnosis. If you have that, that's enough to make your diagnosis. In adults, very similar to children over 6, if you suspect the diagnosis, do a spirometry. If it's negative, do other lung function testing to confirm it. That's what we want to happen in every patient. But we have care gaps. And here's what those care gaps look like in Canada. This is based on the TRACK study, that survey study. About 35% of patients with asthma in the country tell us that they've never had a spirometry test. And 46% of family doctors will tell us that they use spirometry to monitor asthma. So less than half. Now, monitoring is a little bit different than diagnosis, but it gives you an idea that this is a test that is not used a lot. Now, this is a very large study, important study done by a colleague looking at patients with asthma in Ontario over several years, almost 500,000 newly diagnosed patients. And what they found was that less than half, 43% of them, had had a spirometry test within a year of the diagnosis. So they didn't just look back from the diagnosis, they actually also looked forward, with the idea being that sometimes in practice, you have a patient whom you really think has asthma. You can't necessarily wait for the test. You might make a diagnosis. You might even start therapy. But the key is that you then still get the test down the road. A month from then or a few weeks from then, you get that test so you figure out if you were right or wrong with your clinical diagnosis. But what we found was that in Ontario, and it's very similar in other parts of the world, less than half the time was that happening. So we are not getting that objective diagnosis. Here's another way of looking at this question. I put this up because it's a Canadian study led by a colleague in Ottawa, Sean Aaron. And what they did is they took 10 cities across the country and they randomly dialed until they identified a whole bunch of people out there who revealed that they had received a diagnosis of asthma. They then brought those people into the pulmonary function lab and actually tested them for asthma. And what they found, quite surprisingly, was that a third of these people who had been told they have asthma by their doctor did not actually have the asthma when they were tested for it. And really interestingly, and to some extent worrisome, 80% of those people who didn't have the asthma were actually, before that, they were on treatment for asthma. When they entered the study, they were on asthma medications, and they were able to come off of those medications after the testing proved that they didn't have it. We went back in that study to the family doctors and asked them, how did you make this diagnosis? And only about half the time had they indeed done the objective testing, the breathing test that we want them to do. So this fits with the other data I showed that in half the time or less than half the time are patients getting the testing they need to ensure that they truly have the asthma. Looking at it over time, I wanted to put this up because it's a little bit more of an encouraging trend in that what you see here on the y-axis, the height of the bar, is telling you the proportion of patients newly diagnosed with asthma who had a breathing test. And on the x-axis there is over time. So you see that in the 90s and early 2000s, the proportion of patients who had the breathing test was really under 50. It was in the mid 40s, low 40s, but that has increased over time. And by 2018, it's up to just above 58%. So improving, but still more than 40% of people not getting the test at the time of diagnosis or within a year of diagnosis. And unfortunately, although this tells us it's encouraging, what will happen once this goes out to 2020 is, unfortunately, we're going to see a huge drop, probably to the lowest we've ever seen, because as folks out there know, this problem is only going to get worse because of the pandemic that we're in now. We have very limited access to testing. whether you're in a family clinic with a spirometry test available in the clinic, or whether you're in a lab, it's very challenging to do this test because of infection control protocols in the context of COVID-19. So we're going to take a step back with objective diagnosis, and we need to be even more aggressive about tackling this problem for the sake of our patients and getting that diagnosis right. Trying to understand why this isn't already happening. What are the barriers? Why aren't we doing this test more often? Well, patients under 6, for kids, it's not about doing the test. It's about asking the right questions and following the right algorithm to get the diagnosis. Providers tell us that the reason they don't always do it is it's complex. They don't necessarily know those algorithms. And to be fair, those algorithms are pretty new. The Canadian algorithms are out since 2015 and the international ones since 2018. Providers also tell us that, particularly in young kids, they're worried about making a diagnosis and adding a label. They really want to be sure that it's true. So they hesitate, and they also hesitate with treatment because they're worried about the effects of steroids on growth of young kids. If you take a step back, it's often better for these kids to have the diagnosis and get the treatment, particularly when the asthma is really active. But those are some of the reasons that providers are hesitant to get to that diagnosis officially. In older kids, adolescents, and adults where you do have access to the test, the barriers are different. The first problem is that spirometry, which is our starting point, in itself is not a great test, to be fair. In medical terms, we say that it has a low sensitivity and a high specificity. What that really means is that if the test is positive, we know pretty much for sure that you have asthma. We're very confident it's true. But if it's negative, it doesn't rule out the asthma. If it's negative, you have to go on and have another test, call it a challenge test. And unfortunately, in about 60% of the time, it will be negative. So you'll often need that second test. And unfortunately, the second test can't be done on the same day. And it's a test that requires a booking in a lab and an even longer waiting time. So that's where you're seeing some of these barriers. The setting will also matter. So if you're thinking about the office setting where a provider might have a spirometer and might be able to do the test right there and then, that's very convenient. But providers are telling us that, first, they are worried about their own skills in interpreting the test. So they're not all that confident that they'll know how to interpret the results. And the second thing is, whomever is in their clinic who's running the test, that person might be losing their skills over time. It's not a simple test to perform. So they have some concerns around the quality of the test results that they're receiving. So both of those are barriers to them ordering that test. In a lab setting, the big barrier is access. And we talked about how that will be worse with the pandemic in terms of getting access to the test. Also patient inconvenience, patient having to travel, take the time to go, find parking, go to a separate place to get the test. And often there's some pushback from patients. Patients may want a treatment right away, and if they're coughing now, they may want a puffer right away and say, do I really need this test? Can't you just give me a treatment? And so we need patients to also want that test, want that definite diagnosis to know for sure if they have the asthma. And some of that can act as a barrier for providers. So those are some of the barriers around why this isn't happening as much as we'd like it to happen. The bottom line for this point really is that many patients who have been told they have asthma don't have it. Keep that in mind. If you haven't had a breathing test to confirm it, the first step is to ask your provider for that test. And a surprising number of patients with severe asthma symptoms may have a different diagnosis. And that's important because in that study, that national study that I mentioned, there were a number of patients who had serious conditions, cardiac or respiratory conditions, that were being labeled as asthma, and in some cases severe asthma, but it was never asthma. It was always this other condition. And that's why the test is so important. And the bottom line is you have to advocate for yourself. If you haven't had this test, you really need to ask for it and push for it and be willing to go and get it. So I'm going to move to the second question now. Do you really have severe asthma, or is it just uncontrolled asthma? And this really has to do with diving into the definition, really understanding what is severe asthma. How do we define that? So here's what we have, our Canadian guideline recommendation around how to define severe asthma. Severe asthma is asthma that requires treatment with a high dose of inhaled corticosteroids, as well as a second controller. So you need to be on a high dose of the steroid, but you also need to be on a second agent. or you need to have had what we call systemic corticosteroids, which is usually a pill called prednisone, for at least half of the prior year. So if you're someone who is often on prednisone, that might be why your asthma is severe. And those would be the criteria for what treatment you're on in order to prevent the asthma from becoming uncontrolled, or asthma that remains uncontrolled despite being on this therapy. So that's how severe asthma is defined. Now, obviously, this begs the question, what is uncontrolled? If that's how you're going to define severe asthma, you need to understand what uncontrolled really means. So you'll see it's a bit of a rabbit hole of definitions, but then what's uncontrolled asthma? Our guidelines tell us that for asthma to be uncontrolled, you need at least one of these. You need poor symptom control, and by that we mean using our Canadian Thoracic Society control criteria. So you need to have poor symptom control according to those criteria, or according to these standardized questionnaires that we have for asthma. Or you need to have frequent severe exacerbations, in other words, needing those steroids like prednisone at least twice in the last year. Or you need to have been in the hospital in the prior year for your asthma. Or you need to have a significant impairment in your lung function. So you need to meet one of those criteria to have uncontrolled asthma. And the most common criterion we're going to see is that you don't meet the Canadian Thoracic Society or CTS asthma control criteria. But again, this begs the question, what are those control criteria? So we go further down the rabbit hole. These are the Canadian Thoracic Society control criteria. This is what was published originally in the 90s and has been reiterated most recently in 2012. I will say that there's a 2021 asthma guideline coming out. It'll be out in press within days, and these recommendations will be slightly tweaked. These cutoffs will be slightly tweaked, but the idea is the same. We want people to have few daytime symptoms, rare nighttime symptoms, if any, good physical activity levels, rare flare-ups or exacerbations. We don't want them to miss school or work due to their asthma. We rarely want them to need their rescue puffer. And I'll put a line there to say that the ones I've just talked about are the symptom-based criteria. Those are criteria we can ask a question of a patient and they can tell us, and we can figure out if they're well controlled or not. The ones below the line are objective criteria. So has to do with lung function testing. And we want to monitor our patients with asthma in terms of their lung function as part of figuring out if they have good control or not. And so that's what the guidelines tell us we should be doing. And our quality statements reiterate that. So here's quality statement 2 that says that in kids and adolescents, and really it's the same in adults, we want a structured assessment at least once a year to determine their level of asthma control and the reasons that they're not well controlled if they're not well controlled. So this is really important, and the word structured is important there because we want to ensure that the provider goes through each of the questions in that set of questions in the guidelines to determine if their patient has good control of their asthma or not. And so here are some of the gaps around this. I'm going to start with some US data. A colleague of mine who presented this work, she's actually a Canadian, but she did this work in the US, looking at primary care practices. They looked at how often all of the symptom-based criteria were being asked, and that happened in 1% of visits with asthma patients, and how often any one criterion was being asked, and that happened in 59% of visits. So you can see that these questions are not being asked. We did the same work in Ontario. We actually reviewed 4,000 visits with asthma patients in primary care. In only 5% of those visits was control determined according to the guideline criteria. And we looked at almost 900 patients over a year, over multiple visits. Only about 15% of those patients had their asthma control determined, again, according to guideline criteria, at least once that year. So we're seeing that there's a huge missed opportunity here in figuring out if the patient in front of us has good control or not. When it comes to objective criteria, that means looking at lung function and monitoring with lung function, it's even lower. And it's in fact getting worse over time. In 1996, pulmonary function testing was used for asthma monitoring in 14.3% of asthma patients in Ontario. By 2018, that number was down to 6.6%. So we've seen a drop off in the proportion of patients with asthma who are having that regular monitoring with lung function testing. Why is this happening? A few reasons that we understand. partly has to do with patients and parents of children with asthma. They tend to have low expectations of control. They tend to kind of expect to use their Ventolin a few times a day, wake up at night maybe a few times a week. That's sort of par for the course, and they don't necessarily complain when that's happening, even though that would make them poorly controlled by our guidelines. This is a survey in Europe, looked at 8,000 patients with asthma. 20% of them had controlled asthma, only 20, so 80% were uncontrolled, but 90% identified as well controlled. So you can see here that patients are overestimating their level of control. Similar in Canada, this is one of the Canadian survey studies, 85% of patients who thought they were adequately or very well controlled, in fact, had poor control according to guideline criteria. But the problem is also at a physician level. We as providers tend to overestimate control, and we don't probe each of those control questions. We often start the interview with, how's your asthma? And if we stop there, because patients also have a low expectation of control, patients will often say it's fine. And if we don't probe each question, we'll miss the fact that they're poorly controlled. This is some work by Ken Chapman in Canada that showed that if you go to the practice level, physicians will label 30% of their poorly controlled patients as well controlled. So we also are not very good at figuring this out. Part of the reason for that is we don't always know the control questions to ask. This was work in Ontario. Actually, this was work in Quebec, where looking at about 100 family doctors, on average, they knew about 2 of the 8 control criteria. They didn't know what the criteria were. And doctors also tell us that they don't always have time to ask all of these questions, and sometimes they just forget to ask the questions. So there are a whole bunch of reasons this isn't happening. That's the control piece. Now let's come back to the diagnosis of severe asthma. You need to know if your patient's uncontrolled, but you also need to know what therapy they're on, because to have a diagnosis of severe asthma, the patient has to be on the correct therapy and the maximum therapy allowable for this definition, and they have to have gotten there through the right path. And often they don't get there through the right path, and that's where a mislabeling of severe asthma can be made. So what do we mean by therapy? So here's what we have in our quality standards, a quality statement having to do with asthma medication. So the statement says that children and adolescents with asthma should receive appropriate medications and devices based on their age and based on their current level of asthma control. And that includes early initiation of regular anti-inflammatory therapy. Now, in adults, it's very similar. We want adults to, again, be on the right meds and the right devices according to that level of control. And we want them to be on anti-inflammatory therapy. Not always regular therapy, because there's a different therapeutic approach that's been approved in adults recently, where they can be on only as required anti-inflammatory therapy, in fact, 12 and over. But a very similar idea that very early we want to introduce anti-inflammatory therapy, and we want to escalate them according to guidelines. This is the 2012 therapeutic escalation ladder that's recommended in our Canadian guidelines. Again, it'll change slightly in the new guideline that you'll see in a few days from now, but the principles are the same. And I really only put this up to demonstrate that it's complex. There are many drugs. The drug landscape is changing fast. And it's not always easy for primary care providers to keep up with these drugs and to keep up with the recommendations on how to escalate. What that can translate into, however, is patients on inappropriate therapy. If you look at the TRACK study, they found that among uncontrolled patients, a quarter were not on an inhaled corticosteroid, which is first-line therapy, and 42% of those on an inhaled corticosteroid were not on a LABA, or long-acting beta agonist, which is second-line therapy. So these are not severe asthma patients. These are mild patients, but some of them may be severe, but the vast majority are likely mild. But what this is telling us is that 2/3 of uncontrolled patients are not even on first or second line therapy. And that's a huge missed opportunity to get our patients under control. We're not treating our patients appropriately. If you look at it differently, if you look at it through provincial level data, a study done in Saskatchewan, they looked at their uncontrolled patients. 37% were not on inhaled corticosteroid, which is, again, first line therapy. 3/4 of those on high dose inhaled corticosteroids were not on a LABA, which is second line. And that should really never happen. Patients should never end up on a high dose inhaled corticosteroid without a LABA. And this is important because you'll recall that the definition of severe asthma includes a high dose of inhaled corticosteroids, but only if they're also on a second agent. And here's where you have a bunch of patients who are uncontrolled, but they're not on that second agent. So they don't have severe asthma, they have uncontrolled asthma. What are the barriers? Why aren't providers doing better with getting our patients on the right drugs? The first issue is they don't always recognize poor control. We talked about providers just not taking the steps to figure out if the patient in front of them has poor control. But providers will also tell us that they don't have a lot of knowledge of when to start or when to escalate therapy and what the appropriate therapies are. There are some patient level factors, cost, of course, if you don't have coverage, insurance coverage or government coverage for drugs, these are expensive drugs. There's aversion to inhaled corticosteroids. Adherence rates tend to be low. I would say that providers play a role in that. We have to do better at talking to our patients about the pros and cons and side effects and really making the case for why these drugs are beneficial. And finally, outcome expectancy. And this has to do with the fact that we probably need to do a better job of convincing our patients at times that taking these medications really will make them better. So the bottom line for this one is that to have severe asthma, you must have uncontrolled asthma, despite best therapy, or you must need best therapy to remain controlled. And that means that we really have to have a handle on the control level of the patient in front of us in order to properly reach this diagnosis. There are several criteria to make someone uncontrolled. It's important to recognize those different criteria. The bottom line is to truly have severe asthma, you must be on the correct meds, and many patients are uncontrolled because they're not on the correct meds and not because they have severe asthma. So those are the uncontrolled patients as opposed to the severe asthma patients. And to really sort that out, we need to figure out control and we need to get people on the best therapy according to guidelines. The last one I'm going to touch on more briefly is what factors other than the asthma itself may be contributing to your severe asthma symptoms. So something to think about. This is a snapshot of the severe asthma diagnostic pathway in our Canadian guidelines. Again, it reiterates this point, the first point I made around confirm the diagnosis before you go down this route. Make sure it's asthma. You can't be fooled. But then the second thing it says, really important, is that think about comorbidities. Comorbidities are things that exist at the same time as the asthma that may be driving the asthma, making the asthma worse or making it appear as if it's worse, and leading you to a severe asthma diagnosis, whereas really it's not the asthma, it's this other thing. And a few examples here: rhinosinusitis or sinus disease, gastroesophageal reflux or reflux, heartburn, vocal cord dysfunction, I'll talk about that a little bit, and anxiety and depression, which of course can drive asthma attacks and can drive symptoms of asthma. Won't get too much into that one, but let's start with sinus disease. Very common in asthma, particularly because allergic asthma, people who have those allergies, those patients will often have allergic rhinitis or inflammation of the nose and sinuses due to allergies. It can happen without allergies too. It's a common problem. People who have that will often have a post-nasal drip of mucus from the sinuses, which will cause a cough. And the challenge is if they have this, what we call upper airway cough, it may be hard to interpret whether that's the sinus or the asthma. And if they're coughing, we may consider them to be poorly controlled asthmatics, whereas really it's the sinus disease that's driving that cough. So really important distinction to make. It's also possible that inflammation in the sinuses will cause inflammation down lower in the lungs because it's one continuous airway. So the upper airway inflammation may perpetuate that inflammation and drive the asthma to be more severe. In these patients, we like to do anti-inflammatory therapy in the upper airway, so nose sprays, steroid nose sprays, antihistamine nose sprays, sometimes antihistamines by mouth, saltwater irrigation or rinsing out of the sinuses to keep them clear. And then often, if things aren't under good control, we get imaging, like a CAT scan of the sinuses, and we often get the help of ear, nose, and throat, because in some cases we do need surgery to help clear those sinuses. And ultimately, that can lead to improved asthma as well in patients who have significant sinus disease. So something we always want to keep in mind. The other one is reflux or heartburn. That actually occurs in about 80% of patients with asthma, so it's very common. It can in itself cause a chronic cough. So same issue as with the upper airway cough with sinus patients. If your patient has reflux and they're coughing and you're not sort of cluing into the reflux, you might blame the cough on the asthma and you might go down the road of calling them a severe asthmatic, whereas really it's the reflux. So that's an important distinction. But also, to be fair, heartburn can worsen asthma and vice versa. the asthma can actually worsen the heartburn. So those two things are very synergistic with one another, unfortunately. That heartburn with what we call microaspiration could be associated with a little bit of acid ending up in our airways. Obviously, the acid from the stomach doesn't belong in the lungs. It's very irritating to the lining in the lungs, and that can actually make the asthma more active. That can drive the asthma. The way we diagnose this officially is we put a probe into the nose, through the nose, down into the stomach, and we monitor the acid level in the stomach and the esophagus over 24 hours. We can also do it through a scope, endoscopy, or putting a camera down into the stomach. But we often don't necessarily do that test in patients with symptoms. We treat them with antacids, and we see if their asthma gets better, if their cough gets better, if their heartburn gets better. One thing to note, though, is that there was a large study of giving all asthma patients antacid pills, and they found that it didn't actually overall didn't improve the asthma control. So we can't do it across the board. We want to save this for patients who have classic symptoms of heartburn or who have other findings where we suspect they have heartburn or reflux, which could be driving the asthma. The last one I'll mention is vocal cord dysfunction. So our vocal cords are basically the gateway into our lungs. And when we breathe in, they're naturally programmed to open up to allow the air in. Now, if the vocal cords are dysfunctional, they may paradoxically close when we're trying to breathe in, which obviously is a problem because we're not going to be able to get that air in, or they might sometimes go into spasm. And if that happens, the patient will experience wheezing, shortness of breath, cough, tightness, and often that vocal cord dysfunction is triggered by the same things that trigger asthma, like a strong chemical smell or something like an anxiety attack. So it becomes a great mimicker of asthma, and that can be a challenge. The other piece is that not only does it mimic asthma, but it also travels with asthma. So many patients with asthma, some patients with asthma, will also have vocal cord dysfunction. And in those patients, it becomes really important to distinguish what's a vocal cord attack versus an asthma attack, because if we're mislabeling those vocal cord attacks as asthma attacks, again, they can fall into the severe asthma category, whereas really it wasn't the asthma, it was this other problem. What do we do for this? We get ear, nose, and throat physicians involved. We do something called biofeedback. So we let patients see how their vocal cords are behaving and teach them through speech language pathology therapy how to control that better, how to build up the muscles of their vocal cords so that they can control these episodes when they occur. But first, we have to recognize it in order to be able to do that. So to conclude, first thing, objective diagnosis is critical, even in severe asthma. Sometimes it feels too late. By the time we're thinking about someone with severe asthma, they may be on 2 or 3 drugs. It feels like, it's probably too late to go back and try to prove the diagnosis. They very likely have it. But I would say I constantly remind myself as a clinician to resist that temptation. We still must make that objective diagnosis or make every effort to, because sometimes we'll be wrong about that. And that's the starting point. Uncontrolled asthma is not the same thing as severe asthma. Really important to know. You have to have a proper control assessment according to guideline criteria, and you have to be escalated according to the guidelines as well, because both of those are critical pieces of making that severe asthma diagnosis and differentiating severe from uncontrolled asthma. Many uncontrolled patients will gain control with a switch to appropriate therapy, and they won't meet criteria for severe asthma. So that's really important. Must always think about these pieces that can either mimic and or worsen asthma, one being sinus disease, the other being reflux or heartburn, and finally vocal cord disease. And that must be part of the assessment, particularly in severe asthma when we're thinking about escalating therapy and thinking about getting all the way to very aggressive therapies like biologics. So I'll conclude there. This is the Canadian Thoracic Society Guidelines website. If you're interested, all of our guidelines are freely available online. I invite you to visit there, especially in the next few days when the new asthma guideline will be posted. And with that, I will stop sharing and happy to take your questions. Thank you.
Thank you so much, Dr. Gupta. That was incredibly informative and detailed, and your passion for science communication is obvious, so thank you. We actually have quite a few questions, so I'm excited to get started here. So I will just go through them kind of in the order that they came in. So Kim Code asks, how often should you be retested? I was diagnosed in 20s, so it's worse over 50 plus, but can you get rid of it?
That's a great question. There's a lot of debate around is asthma something that comes and goes, or is it something that you always have? And our philosophy has always been that you always have it, and at different times it may become more active or less active. Um, but there are situations in which people's asthma seems to go away. They're pretty specific circumstances, though. One example is people who have obesity and who lose a significant amount of weight. There are a number of studies that demonstrate that the asthma can actually resolve, and that seems to be a phenomenon that lasts as long as the weight is off. So there's that clear relationship between obesity and asthma, and that's one example where it's conceivable that losing the weight might cure the asthma. There are also patients whose asthma is almost exclusively manifest when they're around triggers, particularly people who have allergic asthma, whose asthma is only manifest around particular triggers. So for those folks, when they're away from those triggers, I wouldn't say they don't have the asthma, but for all intents and purposes, the asthma is not active. But for the vast majority of people with asthma, once you've had a positive test, um, as long as the symptoms persist and the story doesn't change, there's no compelling reason to go back and reevaluate that diagnosis unless there's a real change in the clinical picture that doesn't fit anymore. The bigger thing is getting that first confirmatory test. Once you have it, you can be pretty confident going forward that that's what you're dealing with.
Great. Okay, so our next question is from Kim Nash, who says, I have had asthma since childhood and have had a number of spirometry tests. I want to be able to understand changes in the test myself, as doctors don't have time to explain them. Can you recommend a patient-friendly source for understanding the results of these tests? Thanks.
Yeah, that's great, and I'm sorry to hear that doctors don't always have the time to go through it with you. I think we can all do a better job of doing that and going through results with our patients. The number that I tend to talk about the most often with my patients is what we call the FEV1. That's an abbreviation for the forced expiratory volume in the first second. Basically, it's how much air you can blow out in the first second of that maneuver, the breathing test that you're doing. And that gives us a really good idea of how open your airways are, how healthy your airways are. When they get swollen up, that number goes down, and that's an important number. To get a better sense of what the tests mean and how you might benefit from understanding or looking at that test with your doctor, I think it's always a good idea to look at that with your doctor. But the Lung Health Foundation and Asthma Canada both have great resources, educational resources on how you can empower yourself. So I invite you to visit both of those organizations' websites to learn more.
Fantastic, and thank you for that, Dr. Gupta. So this question is from John, who asks, what's the best way to request spirometry or other lung function testing from my doctor? Do you have other tips for how to get my doctor to take my asthma seriously?
Yeah, it's a great question. Myself at the Canadian Thoracic Society and a whole bunch of other organizations are about to launch a public and physician awareness campaign around the importance of getting spirometry done if you're suspecting asthma or COPD. For both diseases, we have underuse of this test. And one of the things we scratched our head on, and we've had patients to help us with to try to answer this, is how do we empower patients to have that sometimes challenging conversation? Because you don't necessarily want to challenge your doctor. You don't want to harm that relationship you have with your doctor. But you want to bring it up in a way that they'll be receptive to it, but you still want to advocate for yourself. And so what's happening with that campaign is we're developing material that the patient can print out and bring to their doctor. And it's material that'll have a logo on it that the doctor would recognize as, so many organizations involved, but Asthma Canada is one of them, Lung Health Foundation, Canadian Thoracic Society, organizations that the doctor will recognize this is a legitimate thing, this is valuable information, and it's an info sheet that the patient would present to their doctor. So that's something that's coming, and look out for it in the next 6 to 12 months. It's been a little bit delayed because of the pandemic. But other than that, I think, before you have a resource like that, I think asking the question, I've heard from patient advocacy groups like Asthma Canada that it's really important for me to have this test. I'm willing to have it. Would you be willing to order that test for me? Because I'd really like to know what my lung function is like. And I think that's a good starting point for that discussion, to be able to have that with your family doctor.
Agreed. This next question comes from Felicia, who says, some studies have looked at spirometry at home. Do you see any promise for this technology to overcome some of the barriers we face today? Really great question.
Yeah, it's a great question. And I like a lot of things have been kickstarted by COVID, the idea of home monitoring for respiratory disease really has gotten a push from the pandemic. Maybe we'll consider that a silver lining. We're obviously doing a lot more virtual care. I obviously am seeing a lot fewer patients in person than I used to. And what that means is that I don't always have the lung function testing that helps me to make decisions and helps me to monitor asthma, like I mentioned, we need to do regularly as part of our control assessment. And that's where home spirometry really has a role. There are many different companies in that space now. We actually have a pilot at my hospital, so I'll know more in a few months in terms of how well it works. But there are many spirometers out there that you can use and that will output to an app on your phone. So all the data are captured there, and it becomes a really nice, easy way to follow your numbers over time. There are even options to share those data with your provider by email. There are some spirometers that actually plug in directly to your smartphone. So there are many different companies that are producing these tools. I think there will be a role. It's obviously, we've had peak flow monitors for many years, but having a spirometry is much more valuable information for me as a provider than a peak flow. So I think it's coming, and I think COVID will push it into the forefront. The prices are coming down on these devices, and what we really need and what is happening in the space is the technology is maturing to the point where we can be pretty confident that a patient is doing it correctly. That's the big thing. There's a lot of training that happens in the lab around getting the right results, but we're getting better and better at having the technology itself be able to determine if it was a good quality test. So we as providers can have confidence in the test that you've done in your home setting. So absolutely that's coming. A lot of the research has already happened, and now it's a matter of getting it in practical use. There are other technologies I'll mention that are a little bit earlier. Oscillometry is another way to measure airway function in the home environment. It's another type of breathing test, maybe easier to perform for patients. And then there are newer technologies like peripherals, like your Fitbit, that can measure oxygen saturation now. Maybe an app through your phone that uses the microphone on your phone. All of these things are coming. So I think there's going to be a whole new landscape in terms of the quality of information we're going to be able to get just from the home setting from our patients with asthma.
Excellent. Okay, just bear with me for one moment. Okay, so the next question is, what happens if your doctor won't refer you to asthma testing and follow up?
That's a tough one. I mean, I would say to you that if you've never had a breathing test and you have a diagnosis of asthma and your provider refuses to offer that test to you, even if you ask for it, find a different provider. That really is a fundamental principle of care, and there's no reason you should be denied that care. Now, sometimes there's a legitimate reason, like in some settings, unfortunately still, that test is hard to access, particularly if you live in a remote community. And we're trying desperately to increase capacity, but there are some settings where it's very hard to get the test, or it's a very long wait time to get the test. But there's no reason that anybody should be outright refuse that test, particularly if they've been given a label of asthma and they've never had that test. It's an absolute must.
Okay, our next question comes from Jonathan, who says, as someone who is a triple threat atopic, asthma, eczema, and anaphylaxis, what are your thoughts on the COVID vaccine's tendency to cause anaphylactic reactions in some people? Worth the risk? Question mark.
Yeah, my answer to that is yes, because that risk remains very low. It is higher in people who have a history of anaphylaxis, absolutely. but we're starting to get a sense that it's very likely the polyethylene glycol. So we know obviously we know what's in these vaccines. We built them ourselves, so we can tell you exactly what's in them. The manufacturers have told us, and the suspicion is it's something called PEG, polyethylene glycol, that's driving those initial anaphylactic reactions that we're seeing mostly in the UK, but also now we've had them in the US, particularly recently with this one batch. But my answer to that is, in the trials, the rate of anaphylaxis was the same in placebo patients and vaccine patients. That's 40,000 patients. Now you get it out in several 100,000 patients, and yes, there are some anaphylactoid or anaphylaxis type reactions, but they're extremely rare, and everybody who's getting this vaccine is getting it in a monitored setting, and the rare patient who's had those reactions, as we can with any anaphylaxis in a monitored setting, was able to be managed and was able to be controlled in terms of that anaphylaxis. So first, it's very unlikely it'll happen, even in a patient with a history of anaphylaxis. And second, if you're very unlucky and it did happen, we would be able to control it on the spot. So those are the downsides. The upside, of course, is getting back to a normal life and ridding ourselves of this horrible pandemic that we're in, and protecting yourself from getting sick. So to me, that balance much favors getting the vaccine, even for you.
Okay, fantastic. I think if there aren't any more questions, I will give everyone just one more second to see if there's anything else. And yeah, okay, we're pretty much at the end of our time, so I think we will leave it there. Again, thank you so much, Dr. Gupta, for your time, like that incredibly informative talk and that really valuable question and answer period at the end. And thank you so much to everyone for attending. If excuse me, if you have benefited from our webinar series and would like to see similar programming, please consider making a donation at asthma.ca. And if you have further questions, something comes to mind 10 minutes after this ends, please do not hesitate to email us, and we'd be happy to help. So thank you so much again. I did put the link to the guidelines that Dr. Gupta referenced in the chat, but when I post the webinar on our website, I'll be sure to include the link there as well. Yeah, so thank you so much, everyone, and stay safe, stay healthy, and thanks again for joining us.
Thank you, everyone. Stay safe. Be well.